Welcome, everyone, and thank you for joining us for a two-part webinar on the A to Z of APDS. I am Martine Pergent. I am the president of IPOPI, and it is my great pleasure to be your moderator today. IPOPI is the International Patient Organization for Primary Immunodeficiencies, and medical education about this condition is one of our most important jobs. Before we begin, I would like to take a moment to thank Farming for making this learning opportunity possible. Today, we will have two guest speakers. Dr. Virgil Dalm, you are an internist clinical immunologist in the Primary Immunodeficiency Center at Erasmus University Medical Center, Rotterdam, the Netherlands. Virgil, your clinical work focuses on care for adult patients with primary and secondary immunodeficiencies. Your goals are to improve early diagnosis, to individualize and personalize patient care in order to improve health outcome and quality of life or in patients with rare primary immunodeficiencies. You will introduce APDS, taking us through the history, symptoms, and the emerging place of APDS in the CVID-CID spectrum. You will also discuss how it is diagnosed. I am also delighted to welcome you, Dr. Maria Elena Maccari from Germany. Actually, you started in Milan, focusing on primary immunodeficiency during your experimental MD thesis at the Teleton Institute for Gene Therapy. You are currently resident in Pediatrics, Department of Pediatric Hematology and Oncology, Children's Hospital Freiburg, with a specific focus on primary immunodeficiencies characterized by autoimmunity and lymphoproliferation, such as APDS. You have been working for several years as study physicians for the APDS registry. You will be talking to us about APDS from a pediatric point of view and spotlight the APDS Level 3 registry treatment options. Welcome to you both. The full bios are posted in the chat. After your presentation, a 10-minute Q&A will follow. Please do use the chat to let us know where you are joining us from. We want this to be an interactive session, so please feel free to say hello. Do use the question tab, which you can find on the right-hand side of your screen. You can ask questions at any time during the presentation and during the Q&A. Without further delay, we will start with this webinar with our first guest speaker, Dr. Virgil Dalm. The screen is yours.
Thank you very much, Martine, and thank you again, IPOPI, for inviting me to be again being part of this one of these webinars, which I'm very happy to do all together with you. And indeed, today the focus of this discussion will be on APDS, or activated PI3K delta syndrome, and some little background, but for most of you, it's all well known. We're talking about what we call inborn errors of immunity. And previously we called these diseases primary immunodeficiency diseases. But over the time, I think the name of primary immunodeficiencies is going to change into inborn errors of immunity, because it's more than immunodeficiencies alone. And as we all know, inborn errors of immunity consists of a large group of genetic disorders. So at current, over 450 genetic disorders have been identified, which give rise to an inborn error of immunity. There are a lot of various syndromes, but the problem is that there is heterogeneity in the clinical presentation. So depending on in which cells are involved or which parts of the immune system are involved, the clinical phenotype of inborn errors of immunity may differ from patient to patient. And as just mentioned, different parts of the immune system can be affected, which gives rise to specific clinical symptoms. One of the clinical hallmarks of disease is recurrent infections, which are important or may be important features of inborn errors of immunity. So if we look at inborn errors of immunity, there are several categories that are recognized, and one of the most important categories with respect to number or prevalence of inborn errors of immunity consists of antibody deficiencies. So primary antibody deficiencies make up approximately to 60 to 70% of inborn errors of immunity. So being in prevalence, the most well-known immune deficiency. So going back to this slide, so one of the clinical hallmarks of antibody deficiencies is or are recurrent infections. So one of the clinical symptoms are recurrent infections. But I think over time we have more and more recognized that antibody deficiencies consists of spectrums of disease manifestations. So on the left hand of the slide, you see, let's say, the immunodeficiency state of the disease. So there is lower production and or lower function of antibodies, which gives rise to the immunodeficiency, which gives rise to an increased susceptibility to infections. On the other side of the spectrum, you have autoimmunity. So patients with antibody deficiencies may have an increased risk of autoimmune complications. Think about arthritis, think about autoimmune skin disease or other kinds of cytopenia, for instance, all kinds of autoimmune problems. And in between, there's also autoinflammatory complications, diseases in which the immune system gets overactive and fights, let's say, their own body. And an example of autoinflammation is granulomatous disease in the lungs in patients with CVID, for example. So it's very important to state that immunodeficiencies or primary immunodeficiencies are not only clinically characterized by an immunodeficiency state, let's say infections, but also give rise to autoinflammation, autoimmunity, and also an increased risk of hematological malignancies. So that's also why the name gradually changes to inborn errors of immunity, because it's more than immunodeficiencies alone. And this is also always a picture that I show to my students when I talk about antibody deficiencies. Like I say, well, it's like a box or a bottle or a bowl of M&Ms. Like M&Ms, primary antibody deficiencies all look like each other in a specific way because they are characterized by low levels of antibodies, recurrent infections, increased risk of autoimmunity, for example. But there are also differences between antibody deficiencies because one antibody deficiency may present with more autoimmunity, while the other may present with more risk of, for instance, malignant diseases. So that's the difficulty in seeing and treating patients with antibody deficiencies. In a way, they all look the same with respect to some clinical phenomena and laboratory findings, but in specific areas, they look completely different. So with the introduction of genetic testing, over the time, we are more and more in the patient group of antibody deficiency, we are more and more recognizing specific genetic defects, giving rise to specific genetic disorders. And the focus of today is on activated PI3K delta syndrome, or APDS, which is caused by a defect in the PI3K CD gene, as depicted on this slide. We only have to memorize that only in a limited number of patients with antibody deficiencies, we now recognize genetic defects. But as the genetic testing is more and more introduced in clinical practice, over time, we will definitely find more genetic defects. But over the past few years, APDS has been an emerging new genetic variant found in patients with formerly the diagnosis of CVID. So what we try to do with genetic testing, think about the ball with the M&Ms. With genetic testing, we try to select or identify specific genetic defects giving rise to specific genetic disorders. And one of those is APDS, as depicted over here. So what is APDS? Activated PI3K delta syndrome is caused by a genetic defect in a gene which gives rise to PI3K delta, which is allocated close to the B cell receptor. And in short, because I don't want to go in detail in this very busy figure, this gene and the downstream pathway are involved in lymphocyte development and thus white blood cell development and involved in B cell and T cell function. So this gene that is affected in APDS is heavily involved in maturation, function, and development of immune cells. So you can imagine if there's a defect in this gene, it has significant impact on the maturation and function of immune cells. It's more depicted in more detail over here. As you can see, just in short, on the left bottom of the slide, this gene is involved in maturation of immune cells. In case of defects in this gene, maturation, function of immune cells may be disturbed. So APDS is a genetic defect. Is it new? Well, if you look at the literature, this was a very preliminary report already published in 2006. It was the first time that the genetic defect in the PI3K delta gene was described in one patient, a boy with a B-cell immunodeficiency. At that time, it was not recognized as a pathogenic mutation giving rise to an immunodeficiency, but it was reported for the first time already in 2006. But it took some years until 2013 and 2014, when two different groups described several patients, as shown on this slide. So approximately 15 patients in both groups having a clinical phenotype of an immunodeficiency and also a genetic defect in the PI3K delta gene. So the first presentation or the first description was already in 2006, but it took approximately 5 to 7 years until other groups confirmed the presence of genetic variants in the gene giving rise to an immunodeficiency. So until now, various genetic defects have been described that give rise to APDS, but as you can clearly see over here, there is one predominant genetic variant that has been described in majority of patients that we know of now. So there are several genetic variants in the gene that give rise to the clinical phenotype. There's one gene defect that is most often described, and over time, new genetic variants are described and will be found, of which the functionality needs to be confirmed. As already discussed in one of the previous slides, APDS gives rise to, let's say, what we call a CVRD-like phenotype. If you look at this table describing the clinical features of patients that were initially described with APDS, those are patients with recurrent upper and lower respiratory tract infections caused by encapsulated bacteria. Those are patients with lymphadenopathy, bronchiectasis, disturbed response to immunization, low levels of immunoglobulins, all clinical features of CVRD. So actually, the first patients that that were described were having a CVRD-like clinical phenotype. Remarkably, in these patients, we found, or it was described, that they have an increased risk of viral infections, they have an increased risk of lymphadenopathy, and increased risk of hematological malignancies as well. And if you look at the presenting symptoms of these patients with APDS, like in common viral immunodeficiency, recurrent respiratory tract infections, upper, lower respiratory tract infections are among the most important presenting symptoms, but patients may also present with viral infections, lymphadenopathy, bronchiectasis, were all seen in this slide. So it has to do, how do you diagnose APDS? What is the important step? What are the important steps to set the diagnosis? Well, I think it starts all with pattern recognition, because as mentioned in one of the previous slides, patients with APDS may have CVRD-like clinical phenotype, recurrent infections, some lymphadenopathy, some increased risk of autoimmune manifestations. But how do you find the patients that have APDS? So you have to look at those symptoms and take these symptoms all together. So the infectious risk, bronchiectasis at an early age, lymphadenopathy, autoimmunity, increased risk of viral infections. Then you think, well, this could be APDS because of the constellation of symptoms taken together. And then, after thinking about the diagnosis is, of course, made by finding the genetic defect. So the key is genetics, because that only proves the presence of a gain of function or loss of function mutation which gives rise to the disease. Further things you can or should do when thinking about diagnosis, of course, immunoglobulins determine the response to immunization. A very significant finding in patients with APDS is the change in the B and T cell phenotype. So that could also aid in setting the diagnosis prior to genetic testing, the specific evaluation of B and T cell subsets. So we have recurrent infections, we have autoimmune complications, a risk of infections in the lungs gives rise to bronchiectasis. Patients have an increased risk of lymphadenopathy, which gives also rise to an increased risk of hematological malignancy. And I think those are really the most important complications that we see and encounter in patients with APDS. And one of an example of a picture over here, bronchiectasis in the patients with a primary antibody deficiency. On the left lung, you see in the upper right corner damage to the lungs caused by recurrent infections, and damage in the lungs leads to decline in lung function and, of course, increased morbidity and mortality. So bronchiectasis is a very important complication in APDS that needs attention. And because of this disturbed pathway downstream from the gene in which the genetic variant is found, because of these defects, there's a defect in the maturation, proliferation, development of our immune system, and this also gives rise to an increased risk of hematological malignancy. Especially B-cell lymphoma are highly prevalent in patients with APDS. So also monitoring, follow-up of patients with APDS to early detect these complications is essential or crucial in treatment regimens for these patients. So I just tried to show you some introduction on the genetic variants found in APDS, the clinical phenotype. So be aware, it looks like CVID, but it may be a bit more than CVID. You have to think about those symptoms together and then consider the diagnosis. And then, what then? Because how do we treat those patients? I will not go into further detail because I will leave this topic to the next speaker, but some therapeutic options are mentioned as an overview over here. So antibiotics, immunoglobulin replacement therapy, immunosuppressive therapies for autoimmune complications, but also novel therapies arise, including gene-targeted therapies or pathway-targeted therapies, which will be discussed in the next presentation. To end my first part of the talk being the introduction of this webinar, I think APDS is a prominent inborn error of immunity. It's becoming more and more prominent as we are able to more and more recognize or find the genetic defect and thus diagnose patients accordingly. And it has all to do with pattern recognition. You have to think about it, or you can think about it if you have specific combinations of symptoms or clinical features. The diagnosis is crucial, so preferably perform genetic testing to prove the diagnosis because it has consequences for prognosis, it has consequences for future treatment options as well. And with having said that, I would like to end my part of the presentation and give the words to the next speaker. Thank you.
Thank you so much, Dr. Dalm and Dr. Maccari. You will now have the screen for the pediatric point of view and the APDS level 3 registry treatment options. Dr. Maria Elena Maccari, the screen is yours.
Thank you very much. I'm also very honored to be here today. And before going on talking about the treatment options for APDS patients, I would like to introduce to you the ASID APDS registry. As you probably all know, ASID stands for European Society for Immunodeficiencies, and it is a non-profit organization whose aim is to expand knowledge on different inborn error of immunities. And the ASID registry collects basic epidemiological so-called level 1 information, but in the case of some disease-specific sub-registries, such as in the case of the APDS registry, also more extensive clinical and immunological information, so-called level 3 information is also collected. And the APDS registry was indeed the first level 3 ACID registry, was started in 2015 and has now a total of 160 patients enrolled and well documented. And it is still growing since we are able to enroll patients, new patients on a regular basis. And as you can see here, it is a huge international effort with many countries participating to the project. The goals of the registry are to longitudinally characterize the clinical and immunological features of APDS, but also to identify stratifying parameters which could allow assessing disease severity, and also, of course, to assess the response to different treatment strategies. The requirements to be able to participate to the registry are a positive vote from the local ethics committee of the documenting center, a signed agreement between the treating center and ACID, and of course, most importantly, a signed patient consent form. The design of the registry is made up by an initial retrospective documentation, which is followed by yearly prospective follow-ups, and regular analysis of the datasets are performed, of course, preceded by quality control and systematic queries for data cleaning of the dataset. The first publication of registry data was published in 2018. And at that time, thanks to the two main cohort publications available on APDS-1 and APDS-2, we knew which were the main clinical features described in the disease. So we decided to focus on another aspect very relevant for this disease, especially from a pediatric point of view, which is the evolution of these disease manifestations over time. And the picture which emerged is one of inborn error of immunity. Oh. So here we are, of an inborn error of immunity characterized by the early occurrence of recurrent respiratory infections, mostly upper respiratory infections, but also frequent cases of pneumonia were also described. And these recurrent respiratory infections were affecting almost all patients by the age of 15 years, also meaning early occurrence of these recurrent infections, followed by the development of chronic benign lymphoproliferation, and then by other features of immune dysregulation, such as enteropathy or autoimmune cytopenia. The registry also confirmed the high incidence of bronchiectasis, and Dr. Dalm already mentioned the importance of that. And bronchiectasis was particularly frequent in APDS-1 patients, and it was also occurring early in life with a mean age at diagnosis of 11 years. Another aspect I want to point out again is the increased risk for lymphoma in APDS patients. And this can be an important aspect also under a diagnostic point of view, because the benign lymphoproliferation typical of some primary immunodeficiencies can be very difficult to distinguish histologically from lymphoid malignancies. And I want also to point out that in the registry and also in the current registry cohort, not only lymphoid malignancies, but also non-lymphoid malignancies are reported frequently. If you now focus on the treatment options for APDS, APDS patients do receive supportive treatment, and with that I mean antibiotic prophylaxis and also immunoglobulin replacement treatment given to more or less 2/3 of the APDS patients in the registry. But many patients do also need immunosuppressive treatments such as rapamycin. Pediatric kinase delta inhibitors as a targeted treatment in this disease are also currently under investigation. And of course, as at the moment only curative option for the disease, there is the allogenic hematopoietic stem cell transplantation. If we look at the registry data, we can see that the patients do receive immunoglobulin replacement treatment starting early in life, mirroring in a way the early occurrence also of recurrent respiratory infections, but pretty early also other treatment such as immunosuppressive drugs, and not only steroids, but also others such as rapamycin or cyclosporin are needed. And as in 2018, when the first publication of the registry was published, 8 out of 68 patients had received transplantation at the time they were enrolled in the registry. And with this graph, I would also like to show you that not only one type of immunosuppressive drug was often given to the patients at the time they were enrolled in the registry, but often many lines of immunosuppressive drugs, meaning not only steroids, but also steroids and rapamycin and rituximab had been given to the patients at the time they were enrolled in the registry. The reason why rapamycin is an interesting treatment option in this disease is shown here. You already saw, together with Dr. Dalm, the complicated pathway of PI3 kinase delta, which is here and is hyperactive in APDS patients. And as you can see, downstream of the pathway of PI3 kinase delta, there is mTOR, which is the component inhibited selectively by rapamycin. At the time the first publication on registry data was published, only few case reports documented the usage of rapamycin in APDS patients. So we decided to have a closer look and assess the treatment response to rapamycin on a total of 26 patients with APDS 1 and 2, where rapamycin were given because of lymphoproliferation, cytopenia, or enteropathy. And what you can see here, everything which is white or gray is a complete or a partial remission under rapamycin. Everything which is black is no response, and everything which is red is even a worsening or a new manifestation under treatment. And it's clear that lymphoproliferation shows a good response to rapamycin. And this is important to notice in the 8 patients who were receiving steroids before starting rapamycin. During the rapamycin treatment, steroids could be stopped or reduced, which is a good sign of treatment response. And it has to be mentioned, however, that 3 patients also received rituximab and not only rapamycin, which of course could have influenced, of course, the treatment response. These results are also confirmed by the visual analog scale you can see here, which reveals the treatment response evaluated subjectively by the treating physician, and the response was evaluated to be moderate or good in the majority of the patients. Regarding allogenic hematopoietic stem cell transplantation, there is a recent publication summarizing the experience with this kind of treatment in a total of 57 patients collected internationally with APDS1 or APDS2. I think it's important for you to notice that the patients transplanted all had signs and symptoms of the disease at the time of the transplantation. So no patient was transplanted with no symptoms yet, for example, only based on the genetic diagnosis. The results revealed an overall survival 2 years after transplantation of 86%, with no significant difference between APDS1 and APDS2, and no significant difference between various donor types, although the most frequently used one was matched unrelated donor, of course, and also no significant difference between various types of conditioning regimens. Interestingly, the authors of the paper noticed that there was a correlation between post-transplant usage of rapamycin and degree of graft instability. As you can see here, the graft failure-free survival 2 years after transplantation was 68%, and they proposed that the usage of rapamycin could improve the fitness of the T cells of the recipient, so of the APDS patients, hereby promoting a certain level of graft instability. It's important to know that very important questions regarding transplantation in APDS are still open and not completely answered. The two maybe most important ones are which is the optimal time and approach for a stem cell transplantation. And this is a question which is difficult to answer not only for APDS, but also for many other similar inborn errors of immunity. And then which is the optimal chimerism needed to obtain phenotype reversion and the best clinical outcome. A few words also on Pediatric kinase delta inhibitors. As I said already, APDS is a rare case of an inborn error of immunity where a targeted treatment is available. Several clinical trials are ongoing in which oral drugs are used that inhibit selectively the Pediatric kinase delta. And also here, pediatrician comment the current trials ongoing are available only for patients older than 12 years old, but this is probably going to change because the trials are still ongoing, as I said. And the first preliminary results have been published already, show good control of lymphoproliferation and in part also of cytopenia. But of course, in these preliminary reports, not enough data available on other clinical manifestations. In general, there was a favorable risk-benefit profile, but of course, also here, longer follow-up data are not available yet. And there is also one form of inhaled Pediatric kinase delta inhibitor, which is currently tested for safety in a clinical trial. So to sum up, I introduced to you the ASIT APDS registry, which is at the moment the largest prospective APDS cohort with comprehensive clinical and immunological information. I showed you that APDS is an inborn error of immunity characterized by the early occurrence of recurrent respiratory infections, followed by chronic benign lymphoproliferation and then other features of immune dysregulation. We both pointed out the high incidence of lymphoid malignancies, and we saw together that both supportive treatment and also immunosuppressive drugs are often initiated early in life in these patients, that rapamycin shows a good efficacy in treating benign lymphoproliferation, but non-lymphoproliferative manifestations do show a less satisfactory response. We saw together that allogeneic stem cell transplantation can be a safe and effective treatment options, but crucial questions regarding chimerism and best timing of and approach of the treatment are still not completely answered yet. And we talked briefly about Pediatric kinase delta inhibitors, at the moment tested as alternative targeted treatment in this disease. Regarding perspectives, especially concerning the APDS registry, we would like now to perform a comparison between APDS and other similar inborn error of immunity is characterized also by lymphoproliferation in order to highlight similarities, but also differences which can be relevant under a diagnostic, but also prognostic point of view. Of course, we would like to gain more data on treatment response and side effects because this is something very relevant for the patients. And we would like to perform comparative analysis between clinical manifestations and immunological abnormalities to look for disease severity biomarkers or correlations between lab abnormalities and important clinical features or clinical courses of the disease. One very crucial piece of information missing in the registry at the moment is quality of life. unfortunately, and this is something which we would really like to implement in the future. And of course, great would be to involve the patients directly in this part of the data acquisition. And with that, I would like to end my presentation and thank, first of all the patients and families contributing to the registry, the three lead investigators, Stefan Ehl from Germany, Alison Conliffe from the UK, and Sven Kracker from France. All the recruiting sites, they are so many that they don't fit one slide anymore. And of course, the all ASID registry team. And thank you for your attention. I'm very happy to take questions.
Thank you both for sharing your knowledge and expertise with us. And indeed, we have some questions. And I will sort them out beginning with diagnosis, then treatment and management, and then registries. But feel free to answer, both of you, of course. The first question is a very important one. At which age is the diagnosis usually posed, and how often the patient are misdiagnosed? How often? This may be a difficult question, but does this happen? I don't know, maybe Maria Elena as a pediatrician?
Yeah. So according to the registry information, the onset of the disease is very early, with a median age at onset of 1 year. So the age of onset is very early, and the diagnostic delay between the onset of the disease and the diagnosis of inborn error of immunity, however, not of APDS per se, is more or less 2 years, according to the registry information. Of course, you're right, that can be then another delay between the diagnosis, recognizing that we have an inborn error of immunity in front of us, and then the genetic confirmation that this inborn error of immunity is called APDS. But between onset of the disease and, okay, this is inborn error of immunity is 2.5 years.
That may be worse when it comes to APDS. And Virgil, this is for you. So a CVID patient could have APDS?
Yes.
And
so
how do we encourage physicians to look beyond CVID?
Yeah, so indeed, that's what we sometimes see in clinics, that we have been seeing patients referred to our outpatient clinic with common fiber immunodeficiency, and then turned out to have APDS. Yeah, so the question is when to think of APDS. So you have two difficulties. First of all, you need to think about underlying inborn error of immunity. And then if you have confirmed the diagnosis of an immunodeficiency, then you have to get one step further to make the diagnosis of this genetic disorder. And I think it all has to do with the recognition of specific symptoms. So one of them could be, of course, laboratory evaluation. So the specific findings that we see in B cell subset differences, so also IgG and IgM, we see in general low IgG and a bit elevated IgM. So these laboratory findings, immunoglobulins, B cell subsets, taking into account also the clinical picture of course, infections with bronchiectasis, viral infections, lymphadenopathy. I think those should be triggers, the combination of one or more of these symptoms that should draw attention and say, well, now we have to consider APDS as an alternative diagnosis for CVID.
Mm-hmm. And moving to treatment, does all APDS patient need IVIG replacement? When to think about starting patient on sirolimus, and optimum prophylactic regimen for patient with APDS? Maybe we can have a section for adult and one for children. I don't know if it differs. You will say.
So I can answer. And that in the registry, 2/3 of the patients do need immunoglobulin replacement treatment because of hypogammaglobulinemia. Antibiotic prophylaxis is often given. And on the other hand, however, antiviral prophylaxis and antifungal prophylaxis are less frequently given to the patients. And rapamycin could be treatment options, I would say, especially for patients showing signs of chronic benign lymphoproliferation. Because in that case, the treatment can be very effective.
Okay, Virgil?
Yeah, so also my experience from the patient, I see that most of patients require immunoglobulin replacement therapy. Take into account the presence of bronchiectasis. I think almost all patients will be on prophylactic antibiotics, azithromycin, which is what we use for bronchiectasis and prophylaxis. So that with regard to the prophylactic treatments with antibiotics and IVIG or subcutaneous treatment with immunoglobulins. And I think indeed in case of autoimmunity, lymphoproliferation, immunomodulatory agents should be considered. Yeah.
Mm-hmm. And in countries where access to treatment varies, what should physician and patient focus on to ensure the best possible quality of life? When it comes to hygiene, vaccine, what would you advise?
Yeah, that's a very tough question, of course, because we always think that if we have a problem, we treat it with medication. And of course, sometimes it's not available that easy in other countries. So I think one of the main problems, of course, for these patients is their increased risk of infectious complications. So prevention of infections is very important. Looking at the example with recurrent respiratory tract infections giving rise to bronchiectasis. So infections are directly involving quality of life, but also for the long term impacting quality of life because of organ damage. So prevention of infections is very important. This can be partly maybe done by vaccination, but the problem, of course, in these patients that they have the tendency to respond less well to vaccination. So vaccination effectiveness is lower. So that also makes it more difficult. So prophylactic antibiotics, adequate treatment with antibiotics in case of infections, that is something to consider if you have only low access to therapies. Those would be the advices, I think. But yeah, prevention is the key. But vaccination may not always work for these patients.
Absolutely. I will go back to diagnosis because we got two questions. One is about especially genetic diagnosis. Can gene panel test pick up APDS? And the other one is, what is the mode of inheritance and what is the current diagnostic delay for APDS? So maybe Maria Elena, I see you're ready.
Yes, I'm ready. So gene panel test can pick up APDS. Maybe I can say again now that I talked about always APDS 1 and APDS 2 during the talk, but maybe I did not specify it well at the beginning. So APDS 1 is caused by heterozygous mutations in the gene called PIK3CD, encoding for the active part of the catalytic subunit of the PI3 kinase delta. And in this gene, there is one mutation, which is by far the most frequent one, and a few others which have already been described. And APDS2 is caused by heterozygous mutations in the regulatory subunit of the same PI3 kinase delta. And the gene causing it is called PIK3R1. And the mode of inheritance is also here. They are also heterozygous mutations, so it's an autosomal dominant disease, with also, however, de novo mutations being described in families. Yeah. And regarding the diagnostic delay, the numbers I already told. So the onset of the disease per se is very early, and then there is a delay according to the registry of 2.5 years before inborn error of immunity is recognized. How long the genetic diagnosis lasts is something I think which is very country dependent. But as I said, gene panels do include most gene panels for inborn error of immunity with antibody deficiency and immune dysregulation include nowadays APDS.
Okay, so delay is there, but it depends on the country, but the possibilities is there. Virgil, do you have any comment on that, or do you agree?
No, I think nothing to add to that.
Well, there is another important question about HSCT. When is the time to think about it? In children, of course, and maybe in adults, you will say. And should you start talking about it with parents at the time of diagnosis, or does it come later on?
Yeah, that is the most difficult question of all. It's very, very good question. And I think it's important to learn more about the course of the transplantation in these patients. That's the reason why I showed the most recent publication about it. Up to now, many patients are transplanted after they develop signs of the disease. And I have to say, in many cases, transplantation was performed in patients suffering from lymphoma. So lymphoma was a striking reason to decide then to go for transplant. But of course, ideally, we would be able to know when it's the best time. So ideally also before organ damage or chronic problems such as chronic viral infections with EBV and CMV, which are very frequent in these patients, occur. But I think, as I said during the talk, this question is common to many other inborn errors of immunity. There is even a study in Europe trying to answer this question, the PCID study, and is a very difficult answer to give. I think it's, however, important now to see that the procedure seemed to be safe for most of the patients and effective. And the optimal, the complete answer, I think I cannot give yet.
Yes, it's still early. And Virgil, what would be the adult perspective about HSCT?
Yeah, well, actually,
when and if?
Yeah, so that's one of the problems that we encounter in adulthood. So we see patients into the clinics, well, when they get adults, and sometimes I see patients that have then APDS, or what was already mentioned, also other inborn errors of immunity. They have complications, they have organ damage, including bronchiectasis, and then you always have the feeling, well, maybe we should have done transplantation when this person was a child, because now we lost the opportunity. But it's always looking, years later, then you see the complications and you think, well, we have lost our window of opportunity. But the problem is, when is that window of opportunity? What is the best time to do transplant? Because you also have to take into account the high risk of mortality of transplanting people. So it's really weighing the risks against the benefits. And sometimes from an adult perspective, we think, we should have done that 12 years ago, but only knowing what we know at that time. So it's really, really difficult.
No, so it remains difficult, as I understand.
Maybe I can add, maybe interesting from this recent publication, actually they did not see, with the number of patients analyzed in the study, which was 57, they did not see a statistically significant difference in the survival depending on the age at transplantation. That's
interesting. Yeah. And coming to lymphoma, any special regular surveillance for malignancy in APDS patients? What would you advise in that?
Also a tough one. Very, very good questions all along. Maybe first thing I want to say, because we talked all the time about this pattern with the recurrent respiratory infections, then the chronic benign lymphoproliferation, and then the immune dysregulation. In rare cases, however, lymphoma can also be the first manifestation of APDS. So this makes it even more difficult to catch it. First thing I wanted to point out. And then regarding the diagnosis, it's very hard to distinguish what is chronic benign lymphoproliferation and what is lymphoma. And I think in these patients, of course, depending also on the clinical condition of the patients and the clinical history, I would always go for a histological confirmation in cases which are unclear, because also other techniques such as imaging or PET could be not conclusive. So in case of doubt, I would go for biopsy and histological confirmation. And as I pointed out during the talk, the histological analysis can be very tricky because even benign lymphoproliferation in these patients can be very particular histologically. So it should be done in centers which are used and trained to see biopsies of patients with primary immunodeficiencies.
Virgil, any comment on that?
No, I fully agree with that. So the problem is that if you make scans of patients with APDS, you see widespread lymphadenopathy, splenomegaly, hepatomegaly, and the question is, how do you distinguish between benign lymphadenopathy and malignant lymphoma? So I think you really should be aware of that and indeed perform biopsies to prove histologically your diagnosis. Yeah. So really.
Oh, sorry. No, go ahead. No, that's fine.
No, so persist on doing biopsies to confirm the diagnosis.
Okay, good, excellent. So my last question will be on registry, and I would like you, Maria Elena, to consider it, but also you, Virgil, from the point of view you have cooperating very strongly with Asia. Does ACID APDS registry accept patient enrollment from countries in Asia? So first you, Maria Elena, and then you, Virgil, how you see that?
At the moment, no, unfortunately, I have to say. I'm not taking the decision per se, but as it is a European organization, so at the moment the answer is no. I don't know. I don't know if there will be other changes in the future, but at the moment, no.
Okay, Virgil, is it worth?
Yeah, so that's yeah. So the case is indeed like this, that the ACID is a European registry, but I think it's very important to have another or the same whatever database open and available for patients all across the world, because the numbers in the rest of the world, of course, also should be higher than expected or than we think of now. And we have to collect those data to learn more. I mean, it has been, I think, very clearly stated also by Maria Elena, the difficulty of getting a good diagnosis, to get the best treatment, when to decide what kind of treatment you should implement. We can only learn from more and more cases. So I think it would be very valuable if we were able to collect cases worldwide to learn more about the disease, diagnosis, prognosis, and stuff like that. Yes, so the ACID database is currently not open for non-European patients, but I think we should think about how to set up a system.
Yeah, and especially have databases that can be interoperable, because this is really good when it begins from scratch.
I agree. Yeah, I wanted to add, maybe actually many countries do have their own registries, and I think this is a very proper way to collect the data, because it's also safe and privacy rules are respected for the patients. It's not only a collaboration between physicians knowing each other, is a registry-based collection of data, and would be great, as you said, Martine, to put the different registry in contact with each other. That would be great.
And also, I understood that the ACID registry was available, not the registry, but the soft, for any country who would ask for that. So maybe this is also something that we can share with our attendees, no? Because this is the best way ever to make them communicate.
Yeah.
Okay, we have reached now the end of this webinar, which was made possible thanks a kind donation for farming. Thank you. On behalf of IPOPI, I would like to say a heartfelt thank you to Dr. Virgil Dalm and to Maria Elena Maccari for this excellent sessions. Also to the attendees, because we had plenty of very nice questions and very interesting one on this very rare diseases. Thank you for the answers you provided. If we did not have time to answer all the questions and some are remaining, you will be pleased to know that we will be sending you the answers by email. Thank you to all for attending this IPOPI webinar. If you have a minute to spare, please share your feedback on this webinar by pressing the link shared on the screen, and the link will also be posted on the chat. Please note that you will be able to see the recording on IPOPI TV within a couple of days, and we encourage you to share it as much as possible, as you can do that who you think benefit from it. And I think that APDS is not so known, so that would be great. See you next time, and once again, a big thank you.